Nice to see you all. So we've got a couple of questions from the one from Twitter, and a couple of questions came via email, which I will ask. But let me start with Sarah first. So Sarah, as someone who lives with obesity, and I'm in the same boat as you. So what do you feel after you've heard all this today?
Yes, I was saying it sounds really promising. Actually, that there's these guidelines are in place now around surgery, kind of having protocols for prioritization, and also with what Barbara was saying around tier 3 and 4 weight management services. I really hope they do start going again, because I think if we listen to what the government are saying, and specifically obviously around Boris saying he wants to kind of have a real look at obesity and how we're kind of looking at people living with obesity, then absolutely what we need to do is offer support, and that's what's massively lacking at the moment. So for me, it's kind of, and I know a lot of our members are kind of saying, well, what are you going to do to support us now? What support is there? And it's really positive to hear that there's kind of steps forward for that. So that's really good.
Okay, so a question came to me from Professor Sharat Tahiri on Twitter, and I will ask that to multiple members of the team, because it's people will have different views. What do you advise your patients with obesity at the moment to do? I mean, we have this epidemiological data, we have plausible mechanistic links, the same links also with diabetes, etc. But what do you tell the patients to do? We are certainly not up and running full capacity providing weight management services or bariatric surgery for that matter. And even before COVID, we were far away from being even close to make a dent in terms of provision of service. Now our patients, quite rightly concerned, quite rightly worried. What do you advise them? So I'll start with some clinicians and then I'll move to the surgeons. I guess, Barbara, what do you think?
Well, luckily where I am, we've restarted both tier 3 and tier 4 services. So what we are doing is actually we're trying to identify the high risk patients that will, in a sort of similar fashion to those that have to, should be progressed into bariatric surgery. We're trying to highlight those patients and especially those with type 2 diabetes. We're trying to optimize them, I think as I've shown, it's really important to manage their hypoglycemia, to introduce agents that will also help with their weight, such as the GLP-1 receptor agonists, as well as the combination with SGLT2, as long as it's done safely. A lot of these patients have been shielding anyway, so but I mean, in terms of actual intervention, bariatric surgery has been on hold. I think I know somebody was asking about, other gastric balloons or endoscopic procedures. They've not been happening either. That's not been an option. The pharmacotherapy options we have are hands-tied, as you know, because we've got very little that we can do. So it's very much about lifestyle. And, I think there are different patients, and some are still quite happy to consider a very low calorie diet. And we have had this debate, is it safe to propose a very low calorie diet in a time of COVID? And we've searched quite hard to look at the evidence for this. And actually the evidence in terms of, the immune system, or what happens to the immune system, I think there have actually been some studies to compare very low calorie diet, indeed to bariatric surgery, Francesca, as well. And the evidence seems to suggest that it's fairly safe, that there is no impact on the immune system. And therefore, we are still advising patients who would like to undergo a very low calorie diet within our tier 3 to do so, or other patients a more sort of moderate calorie restriction diet with, of course, exercise, encouraging exercise. And then we're also quite lucky that we have a psychologist attached to our service, both tier 4 and a different one for tier 3. And again, trying to, identify patients that will clearly need psychological support, throughout their sort of obesity journey. So that's how we're doing it. But of course, this is not what's happening up and down the country. And I think, I open it up to, Carl or other people to see how, how they're practicing, perhaps in Ireland, and you can share your experience.
Thank you, Barbara. Carl, what are your views?
I think we need to see the perspective that in the next 12 months, in many countries, there'll be more people dying with obesity and diabetes who do not have COVID-19 than people who die with COVID-19. So we are dealing here with diseases that are killers. and postponing treatment is going to shorten people's lives. So we really need to work out how we can treat patients with obesity within the context of this virus epidemic that we're having now. So those are challenges, and I think lots of people are raising to it. So I think all the treatments are in play, and it's again, we need to be able to get the treatments to patients, and of course, patients will have a different level of expectation. Some patients would like to present for treatment, and other patients would like to be more conservative, and that is okay. So we should not force people to have treatment, but equally we should not deny people treatment who would like to take the next steps.
Thank you, Carl. David Hopkins, I've got two Davids. I need to be very specific in who I'm talking to. So David Hopkins, what are your views? Patients are worried, and they are quite, right. So how can we handle this situation?
In terms of dietary management, I'm just encouraging people where they want to do without putting any kind of pressure. It's quite interesting. Quite a few I've spoken to with diabetes and weight issues have actually been fairly proactive through COVID. And for all the ones who've sort of gained weight because of concerns about exercise, we had a lot of people actually trying things out themselves, particularly around low-carb diets, more than VLCD. Obviously, real concerns with diabetes about attempting any kind of VLCD without appropriate supervision, particularly for those on insulin. And that's something that we can't offer at the moment because our teams are so stretched. But just on an anecdotal basis, the number of people are doing quite well with particularly low-carb diets and making their own adjustments has been quite high. So, I've just been proactively supporting people who want to make change. But that's about the best we can really offer.
Excellent. And in terms of supporting them, are we supporting them remotely via virtual environments, or are you supporting them via other means, face-to-face, for example?
Only at the moment virtually.
Yeah.
And that's one of the challenges we have. So we haven't resumed any real face-to-face activity.
Yeah. Professor Kerrigan, David Kerrigan, so from bariatric surgery perspective, again, there are lots of people who are on the waiting list. There are a lot of people who will benefit from bariatric surgery. And the waiting list will be increasing now across the country, almost certainly. How do we deal with this? How do patients what are patients supposed to do? What are we supposed to do to be able to handle this?
There's a couple of things, really. I think one of our priorities when we first were affected by this is to make sure we could look after the patients we'd already treated. So we immediately moved very quickly to remote consultations, which actually have turned out to be incredibly popular with the patients. And we very quickly, again, moved to keeping the whole multidisciplinary assessment of new referrals going using remote MDT consultations. We do patient education remotely, sharing PowerPoint presentations via Teams. It's actually worked very, very well. And I think that's been good for patients because they can see that the whole system hasn't ground to a complete halt. They're very understanding and accepting, I think, of the fact they know we can't bring them in for surgery straight away. Although, fortunately, our first list is on Monday, which is great. So we're starting up again. Yeah, so I think patients have been understanding. We've just tried to keep the support going by keeping the system moving so they're not stuck in it and they're still moving along the pathway. So I think that's been good. From a BOMS perspective nationally, we felt very let down by the Royal College of Surgeons because when they produced some prioritization guidelines, they didn't even really mention bariatric surgery. And some hospital managers have taken that as a signal to say it's even sub-priority 4. And so we've had to try and counter that stigma. And we've been supporting members. We've had a really good task force meeting today with about 14 UK bariatric meetings just to share information, best practice, support each other. BOMS are sharing documents amongst our membership, such as enhanced consent processes for the COVID era, so that's all in place for the hospital managers to see, okay, patients are very well aware of the additional risks they may be taking. And we're very upfront and frank about that. I haven't had a single patient I'm aware of who's actually not signed that form. They're still very keen to proceed. We're also lobbying and trying to get some political influence, partly through APPG, but also various other routes to try and get government to recognise that this is a priority and that it is something that they need to invest in and invest significantly in, both in terms of an early resumption of bariatric surgery, but also in terms of an increase in the numbers. Over the last decade, we've seen a real fall in numbers. 10 years ago, we were doing 9,000 NHS-funded bariatric operations. In the last financial year, it's 4,700, half the amount. And we as a society have been pushing for government to increase the number gradually over the next 2 to 3 years from 10 and up to 20,000 operations a year. We've got the manpower to deliver that, and compared to other countries with a comparable population like France, who fund 60 to 70,000 state-funded procedures, 20,000 is not asking for the end, for everything really. I think it's an achievable goal.
Thank you very much for this insightful answer. I don't know if Kamlesh is still with us or gone, but I was going to ask him with Stephanie about, so actually you guys see the vast majority of people with type 2 diabetes and obesity. We only see the tip of the iceberg, the hospital guys. How are you dealing with them, especially those who are really concerned?
So the patients who have obesity tend to be the ones who are chatting more. I think patients with type 2 diabetes and type 1 diabetes have had a lot of information from professional associations.
Correct.
Patients with obesity have been struggling a lot more. I think the biggest message that I've been trying to get out to colleagues is not to shame patients into losing weight at this time. I think I've seen comments like, oh, well, perhaps they'll understand now that they should lose weight and then they won't die. Really unhelpful things like that. And I think it's really important that you have a stressed cohort of people. We're all stressed. This isn't a normal time. They will be struggling more. As someone said at the beginning, food may be different, income may be different, lifestyle may be different. And this is not the time to be trying to shame your patients into losing weight. So that's the first message that I think is really important. If patients have suddenly thought, do you know what, I'd quite like to do something about this, then managing the normal range of interventions. But, like I always say, take a good history, take a proper weight history, do all the things that you absolutely need to do for patients who are living with overweight and obesity, and then offer reasonable options, just a small amount of weight loss, like the things that we've discussed a lot, because we know that trying to suggest to someone that they need to get rid of their obesity right now is simply not an option. So it's kindness, it's not shaming them, because that's never going to work. But if you have people who have suddenly decided, actually, this is the time I might think about this a bit more, then working with them to help them by giving them realistic goals.
David Kerrigan, yes, you wanted to say something.
I just wanted to ask my non-surgical colleagues your view, just thinking about rapid weight loss with surgery. Do you think there is an argument that, whether it's an argument on the pro-inflammatory side of the equation or on the actual loss of weight and the effect on respiratory reserve that might have, do you think there is an argument that we should be saying to government they need to actually rapidly start surgery, because it would potentially, it's the only treatment that may shift 3 or 4 stone in a very short period of time? Is that going to move a susceptible group of people with type 2 diabetes and obesity living with those conditions out of harm's way? Is that a valid argument, or is that just surgeons looking for a nail to hit with their hammer?
Carl, you want to...
Yes, so I think, the first rule is always do no harm. But what we really want to know, and I'm sure it's happening at the moment, I just haven't seen the data, is do we know if patients who've had bariatric surgery in fact have a lower risk of developing complications with COVID-19? So in the UK, we have the very good register, and there's excellent registers across the world. That would be a critically important place, to start. Maybe before we can say actually talk about mechanistic changes like early and rapid weight loss. I think mechanistically, and arguing from first principles, I could see the value in that. But I think the first place to start is do people who've had bariatric surgery have a higher or lower risk than comparative groups when it comes to complications of COVID-19?
I could completely agree with Carol on that. And in fact, one of the things we've put in place with the resumption of surgery is we're using the MBSR, which is an incredibly powerful tool. And we're actually getting weekly reports that are distributed. So every patient, we're looking for almost real-time reporting of patients. There are automatic flags if anybody gets transferred to intensive care. And that actually involves a phone call immediately from the lead from the MBSR that day to find out what's happened. And it's incredibly tight, close monitoring of the patients we are operating on. So if there is an uptick in unexpected complications because there is a problem, even in a relatively COVID-free environment, then we'll see it straight away and we can withdraw. And I think you're absolutely right, Carl. We haven't got any information, we haven't got the data, and we need that.
Absolutely. Barbara, you wanted to say something?
Yeah, I'm not sure whether this is published or well, no, it's definitely not published, but I think NHS England is trying to look at this, because the problem I think with the database, it doesn't quite link in with the these sort of GP.
COVID, yeah.
Yeah, exactly. So who's been?
I had the same problem.
But I think I hear that out of 6,000 surgical procedures in 2019, and like I said, this maybe we should stop the recording now. But anyway, this has been like 2 deaths or something. So very, very, very small. I mean, just tiny. Again, reinforcing the fact that I think it's safe. I think I'm hoping this will come out. But I think it is very safe. And again, David, I'm very happy to also send you the paper about the sort of comparing very low calorie versus bariatric weight loss in terms of the immune system. And this it may well be that we're getting this sort of pro-inflammatory sort of it's an improved inflammatory picture very, very quickly. But we don't know that. Obviously, we'd have to do a prospective study, randomizing patients and hoping that they catch COVID and looking at outcomes going forward to specifically answer that question. But I think from what I understand, I think it's very, very safe, and the mortality is very, very low. But again, unpublished, and I'm not even sure I'm supposed to share this, but it's...
Yeah, well, the latest MBSR data cuts is about to be published, and you're absolutely right. The risk of the mortality, 30-day mortality, is 1 in 1,400 at the moment in the UK.
Exactly right. Exactly.
The risk of 30-day mortality in hip fracture surgery is 6%.
Yeah.
Excellent. Have we lost? Oh, Stefan is here. I was looking. So Stefan, from a German perspective, from Germany perspective, do you do things differently in Germany, or is it exactly the same troubles we are having in the UK?
Well, I think there's a big difference in terms of what we have been talking about regarding elective programs. So in Germany, especially the eastern part where I'm right now in University of Dresden, we didn't have this kind of numbers and lockdown. So elective programs with a very, very short period, maybe a week, even less than that, were fully running. So in that sense, it's quite a different situation. On the other hand, we do not have a lot of, not as at least as in London, bariatric programs. The ones we have, some of them in the community hospitals, started timely. So 2 months ago, I guess. So it was only shortly interrupted. So from the patients I have seen, interestingly, about 10% lost weight because there was, as you know, COVID-19 associated gastrointestinal diarrhea. So some of them really had severe diarrhea. I had some patients losing 20 kilos or something. It was quite stressful for them. In general, on the other hand, the majority, 80 to 90%, put up weight. So I was surprised to see some of them coming back to the clinic with quite traumatic increase in obesity. And some of those patients that really had made a decision before to avoid bariatric surgery, to try very serious weight losing programs, And this was now hampered and impaired by the corona months, that they stayed at home, and staying at home is always, you are deduced, it's also to more food intake, obviously.
Yeah, it's quite interesting. I mean, I actually, when I had COVID, I lost 14 kilos in 7 days, even without the GI symptoms. It was terrible.
Yeah.
I'm surprised I'm still here, but I'm lucky to be here. So two questions related to each other's. Do you think there is any role in this period for gastric balloons, endoscopic sleeve gastrectomies, and what about bariatric surgery with the private providers in this time? And I think, David or Francesco, let's start with David.
Well, private providers, obviously the NHS has contracted to buy in a lot of beds and theatres. They haven't actually utilised those beds and theatres in the private sector. So there's a bit of an argument going on between the NHS and the Treasury at the moment about how much more money they're going to be given to carry on that contract. But I think there is a need to try and just clear the backlog of NHS surgery by using the private sector. I think that's probably a good idea. I think for bariatric surgery in particular, the private sector does offer a separate site to a main hospital. So you can obviously divide your hospital into hot and cold sides, but actually if you have one that's completely separate and is a purely cold site, that's probably the safest environment for bariatric surgery. So I can see a role for that. However, some private providers are anxious about restarting bariatrics. And I know from a conversation with the medical director of the Nuffield Group, for example, they do not want to be first mover on this. They're putting it off and kicking the can down the road till August to see what happens. So I think, yes, there is a role. The endoscopic balloons, just briefly to touch on that, balloons are a short-term thing. It's not a durable weight loss solution, so I wouldn't be going down that avenue. Endoscopic sleeve gastrectomy, the jury is still out on the effectiveness of that. We're getting some data, but it's by no means mainstream at the moment. And it's still an aerosol generating procedure that requires a general anaesthetic, so you might as well do a bariatric operation in theatre if you're going to be doing one of those.
Excellent. I'll come to you, Stephanie, in a minute. Francesco wanted to add, I think, something to that.
No, I think David said it very well. I saw
Excellent.
both Sarah and Stephanie raising their hands.
Yeah.
I'll leave it to that.
Yeah, Stephanie, please.
One of the things I've had patients coming and asking whether they should go to some of the private weight loss clinics for skinny jabs. Other brands are available, as to whether that's something that they should be doing now. And I think that might be what Sarah was alluding to, that kind of services. And I think that I've been suggesting that this is not a good time to be doing that. I think that for patients who, for very obvious reasons, will then be on medication that could potentially be causing them difficulties. And so I've been not suggesting to patients that that's a good idea, and suggesting that actually this is not the time for that.
Tara, did you want to add any point about that question?
No, I've been approached, Obesity UK have been approached by people recently, so from kind of the private sector to who are looking at kind of changing their practice potentially and improving their services and kind of all this kind of thing. So I just wanted to try and get a feel for what people's thoughts are, because obviously if the NHS doesn't have the capacity, then obviously it is an option for people if they are wanting surgery now and they're not able to get it in their locality. I was thinking that there is a space for it there. But I agree with Stephanie around, the likes of, Skinny Jab, etc., who are, selling a prescribed drug, but not potentially in the correct way. That's not a positive. So I'm just thinking if there are people that are actually going to follow due diligence and actually providing a service that's actually totally above board and actually really, another option, is that a good thing to have? Because obviously if there are CCGs like where I live in North Yorkshire, for instance, there isn't any weight management services. So actually, where does someone like me go? I just think that was why my question was really just to see if there is scope for this to fit into the general area, really.
Okay. Thank you very much for that. So I think because of time, I'm going to thank all the panelists and the speakers for their great contributions, and I'm going to hand over to Simon and Francesco to close the meeting. It was a great pleasure talking to you all. Thank you very much.